Now I would like to invite Dr. Rahul to give a short presentation and take us through what is Apollo Connect.
Good morning, dear doctors and esteemed guests. Thank you for joining us today. I would just like to quickly take you through what Apollo Connect is. I know quite a few of you have already been associated with Apollo Connect in its earlier version. With the feedback that we have received and the guidance from respected chairman, sir, we have taken this to the next level now. And as Dr. Vikram Salam mentioned, Apollo Connect is a connected care partner network where we are trying to address the key challenges that the healthcare system faces today. We've seen that there is increasing competition and changing patient preferences. All markets are seeing an increase in competition for secondary and tertiary care, leading to pressures on our revenue and profitability. We also see that patients, and rightfully so, are demanding superior care at an affordable rate closer to their home. At the same time, we are also seeing opportunities. We are also seeing opportunities afforded to us by rapidly evolving technology, allowing us to provide care irrespective of distance. And when we add the power of networks and collaboration, we see a way to provide superior care, build lasting relationships, and collectively enhance our brands. Next. So, as our founder chairman, Dr. Pratap C. Reddy, built Apollo with the mission of providing healthcare of international standards to every individual. Towards this mission, he believes that it is important for all of us as care providers to collaborate and support each other to ensure that no sick person goes untreated. To help achieve this goal, he has envisioned Apollo Connect with 3 key goals. One is provide superior care to all patients. Second, keep patients closer to home as far as possible. And ensure that our partners also grow along with us. With this, I am honored to introduce you the Avatar of Apollo Connect, which is a pioneering initiative to help patients receive superior health care and provide significant benefits to the partner hospitals with Apollo's support. Apollo Connect brings together many services and expertise from across the Apollo ecosystem to help network hospitals increase revenue, lower costs, and gain a reputation for providing superior care. The first key set of services are curated to help you improve revenues and cut costs. These include support with procurement at preferential prices, remote ICU support, specialist OPDs at your premises, and the provision of advanced diagnostic support at your hospital. The next set of services helps you retain patients at your facility and provide a wider range. Next slide. And helps you retain patients at your facility and provide a wider range of services to them. Through telemedicine, we are able to provide urgent ER and ICU support for emergencies and specialist opinions for complex cases. This reduces the need to transfer patients to higher centers and helps you retain the patient and lets the patient be closer to home. Specialized radiology reporting and remote support for many other areas that provide a wider range of services to your patient without having to do investments in costly technology. Our expert support is also available to help you address your most pressing clinical, business, and operational challenges. Scheduled clinical and quality trainings will also be provided to your teams. For those hospitals which are seeking NABH accreditation, our quality teams are available to assist and guide you. We also have a host of training and mentoring programs which have been designed to help your hospital's doctors, nurses, other executives, and especially the next generation of leaders from your teams. Next. All of these services are available through a next generation online platform, which is easy to use and access, can be accessed from any web browser on a modern computer. This helps us reduce the infrastructure requirement at your end and the investment required for this. With this extensive list of services, our aim is to help you improve your profitability. Next slide. Our aim is to help you improve your profitability, and our teams will be happy to work with you to show you the real benefits that can accrue to your hospital, apart from the intangible benefits that Apollo Connect brings. Next slide, please. The Apollo Connect branding is designed to convey the collaborative nature of the program and the trust and quality that comes with it, along with it. There are 2 subscription models available depending on the need of your hospital. And we will be happy to have one-on-one discussions with you and your teams to help you choose the right one based on your needs. We have also benchmarked our program against international standards, especially what Neo Clinic provides. And as you see, there are significantly more services available at a lower cost. So with this, I would like to thank you for your patient hearing, and I hope you find the program construct beneficial. I look forward to working with you all to build healthcare together. Thank you.
Thank you, Dr. Rahul. Now I would like to invite Dr. Ramakrishnan, Director and Senior Consultant Critical Care Services, to enlighten us upon the clinical aspects of Apollo Connect.
Morning. It's a real pleasure to be here. I have been with Apollo Critical Care for the past 20 years, and I just wanted to focus on how this whole thing has evolved, how we have been providing critical care, and how this program could really enhance the care for critically ill patients, not only in our hospital, but everywhere. Whenever our chairman and vice president, vice chairperson used to talk about care in the hospital, they used to use the word TLC for tender loving care, which is absolutely important. But I think today we will talk about a different TLC, which is technology leveraged care. And that's what we're going to do in the critical care. So when we started managing the ICUs, those days I'm sure a lot of you would remember that we used to have the code blue teams for managing cardiac arrests in the wards. And at that time we felt, why should there be cardiac arrests happening inside a hospital? Because you should really try and prevent that, and we should have probably identified that problem earlier. So we evolved a system called Medical Emergency Team, which is a team comprised of doctors, nurses, technicians who are qualified and experienced in providing emergency care. And we started the Medical Emergency Team, which would, whenever there is any emergency in any of the wards in our hospital, the team used to be there. Not only their expertise, but also have the necessary equipments that are required to handle an emergency. Because that is another problem that we face whenever we go into the wards. They may not have the same kind of medications, equipment that is required in the ICU or when you're managing an emergency patient. So once we started the medical emergency team, we clearly found that the number of cardiac arrests had significantly come down, close to zero in our hospital. And subsequently we said, okay, still when we are looking at these patients who are having emergencies and getting transferred to the ICU, some of them are extremely sick and we sometimes lose them a few days later in the ICU. So then we said, maybe we should identify this even earlier than waiting for a medical emergency team's call for us to go and handle the patient. So we started something called a pre-med, where we engaged ICU nurses who would literally walk around each of our wards, identify patients who are, either sick or having some complaint. So it's like a quick round that they do, but they're able to identify sickness or identify what we call the early warning signs of sickness. And they are trained to do that. And we found that the number of transfers was getting less to the ICU, the number of worsening sickness was also getting less. So we then had a pre-med team successfully implemented and taking care of all these patients. Now we are moving to the next level, where we say that, yes, it is physically a person walking around and doing this. But is there any way that we can monitor these patients who are in the wards, not only in our hospital, but anywhere where we could probably identify early morning symptoms or signs of sickness and therefore alert and take care of them earlier to prevent deterioration? I think that's the whole logic and science behind this, as I said, leveraged model, technology leveraged model that we are doing. And Dr. Rahul has already explained on how it works, and we'll be happy to answer some of the questions that you may have on how it is done. But the model is that today, more and more patients are being managed either as outpatients or as day care surgeries. I mean, what we used to do by admitting patients like chemotherapy or cataract surgery or orthopedic surgery, today we're all sending them out very, very quickly, which means the patients who are inside a hospital, whether they are in the ICU or whether they are in the ward, are extremely sick, and they need that kind of monitoring to identify the problem early so that we can take care. So the enhanced connected care model will help to identify vital signs remotely and alert you in your units or wherever in the hospital so that we can take care of the patients earlier. We also will have the EICU or the tele-ICU model where if you do need a consultation, we are available as consultants to support you. And whenever we say tele-critical care or EICU, a lot of people ask, how can you provide critical care remotely? Honestly, when we are providing critical care, I would say a good 60 to 70% of the care is cognitive. Another 30 to 40% of the care may be procedure related, which we cannot do when we are doing remotely, but we can tell you that this is required or you need to transfer. But the remaining 60% of the care can be provided by competent, trained intensivists remotely. I would stop there and thank you all for coming. And we are all really excited about this enhanced connected care. And we really want to break our walls in our ICU, reach farther, and that's the whole idea of the connected care. Thank you.
Ladies and gentlemen, we can have an open Q&A session. I would like to invite Dr. Ramakrishnan sir and Dr. Rahul for the Q&A session. Ladies and gentlemen, our beloved and visionary chairman, Dr. Pratap C. Reddy, has arrived. I would like everyone to stand up and please greet our chairman and welcome him together. May I invite Dr. Maruthi Krishna from Maruthi Hospitals, Tirupati, to welcome our chairman. So, please.
Like we should.
Can we play the testimonials and short clippings of the network hospitals?
Myself, Dr. Mahesh Kumar of Mangalam Multi-Specialty Hospital, Bhagalpur. Today, we stand at the threshold of an innovative era where medical expertise transcends physical boundaries. It is with immense pride and anticipation that I introduce to you the Kolkata Apollo Tele ICU Hub. We bring together the finest critical care specialists renowned for their expertise, experience, and unwavering dedication for the citizens of Bhagalpur. We are saving life of emergency and critical care patients receive their priority care. Experience reduced response time, quicker intervention, and the reassurance that they are under the care of best minds in critical care medicine.
We have
This is Dr. Deepa Priya, Managing Director. Hello, this is Dr. Deepa Priya, Managing Director of GG Hospital, Pattabiram. We have been associated with the Apollo Hospitals Group under the concept Apollo Connect, a tie-up which has been successfully helping us for managing our emergencies and critical care departments. Thanks for this wonderful concept, exclusively tailor-made for the secondary care nursing homes, which motivates us to handle all kinds of emergency cases. Thanks to the founder and chairman, Apollo Hospitals Group, Dr. Pratap C. Reddy, sir. Thank you, Apollo Connect.
Dr. Naveen Prashad, Director, KC Hospitals, RV. We have been associated with the Apollo Hospitals Group under the concept of Apollo Connect. And in this concept, we have been linked virtually for emergencies and intensive care, in which we get expert opinions and consultations from super specialty and such clinics like infectious disease, hepatologist, hepatologist, and other specialties. In this, we share our reports and patient's condition with the patient, with the consultants, and on their advice, we come to a diagnosis and also treatment modalities for these patients. So this concept, which has been founded by beloved Dr. Pratap C. Reddy, who is the founder of Apollo Hospitals, which is a great initiative, which is helping hospitals, secondary hospitals like us, and indirectly helping the local community. I thank wholeheartedly Dr. Pratap C. Reddy, founder and chairman of Apollo Hospitals and Apollo Connect.
Now I request Professor Ravi Mahajan, Critical Care Integration and Transformation, Director, Research and Innovation, to take us through the virtual tour of our command center.
Thank you very much. Welcome to the program of Apollo Connect. Nationally, as we know and we've heard, that we are all seeing growing number of patients who may be vulnerable because of their frailty or multimorbidity. We're also well aware that these patients require care every now and then, and they require continuous monitoring. So using our command center approach, can I have the video, please? As inspired by our chairman, we will ensure that these vulnerable patients are continuously being monitored irrespective of their geographical location. Using our unique EMR platform, our team of trained personnel will monitor your patients, whether they are in EICU, emergency rooms, home care, or in the ward care. At present, as we speak, we are monitoring over 1,500 patients in our ecosystem. Using wearable devices, their heart rates, ECGs, blood pressures, respiratory rates, and body temperatures are continuously being monitored in the command centers. And our analytics, as you can see here, shows that the precise location of these patients. Any deterioration in their condition will raise critical alerts, which will be picked up by critical care teams, and our team will then liaise with your team to ensure that an alert is being responded to and that your patient is getting the due and timely care. You can thus be assured that your patients will be monitored 24/7, 365 days, and if you felt that you required second opinion or an expert opinion, that will be arranged there and then, and our experts will work with you to get the best possible care that your patients deserve wherever they are, therefore minimizing any need for their transfer. Ladies and gentlemen, the Apollo Connect brings you multimodal, multi-speciality, multidisciplinary command centers to help your patients to get the treatment where they deserve and right treatment, right time to the right patient. We already have these command centers in Delhi, Mumbai, Kolkata, Hyderabad, and Chennai. BG Road, Bangalore is going to have command center soon. And we sincerely hope that these command centers will play significant role in connecting you all with us and in bringing the right care to the right patient at the right place. Thank you very much indeed. Thank you.
Now I request and invite our honorable and beloved chairman to address the gallery.
I must say, I'm happy to see all of you. You know, it takes me back when we started the hospital. This auditorium was filled on Sundays. Well, we had special topics, and it ran like that every for 5, 6 years. And suddenly it disappeared one day, and we all know what it is. They started Mahabharata, and everybody started looking at that, and then this hall was empty on Sundays. So it brings back that, seeing all of you today. I was wondering how to accommodate more at that time. Actually, it's the same problem today. But I'm very happy to see all of you. And you all know what Apollo is. But I would like to bring you back a few things. What made me do all this? Way back in 79, November 9, I lost a young man who was only 38-year-old. You know why? He had coronary artery disease. He was being treated with him by Mother Monica. And the medicines would die. So the only solution in medicine is that is today plastic, but those days there was no plastic, just CAV. There was no acceptable program in the country, so I used to send all my patients to my good friend Denton Cooley in Houston. He had an appointment in October. Unfortunately, he couldn't raise $50,000 and he lost his bike. Leaving behind an young wife and 2 children. This is what started me saying, why should we? You know, if Indian doctors, Indian scientists, Indian engineers are far excellent towards it, why can't we have that back here? But, you know, in 70s, you know the bureaucracy in the country. So I made more than 100 trips to Delhi to make them understand that there is a need for it and we are capable of doing it. So this is why I think the whole thing changed after a few months. So our anniversary is coming, 40th anniversary, September 16th, September 18th, 1983, when our first hospital, Gandhi Rail Singh, inaugurated. I still recollect. He had his surgery a few months before going to Houston. So he came here for half an hour. So he spent 1 hour, 45 minutes just going around the hospital. Oh, Houston, he went on Hindi. I don't know Hindi. But he went on Hindi commenting. And he threw his speech and spoke for 45 minutes. So I think that was the beginning. But there was a lot of people who believed, what can he do? You know, some people in the lobby said, Dr. Reddy is a very clever guy. He has built this to become a 5-star hotel. But what did we do? We announced a 9-star hospital. Thanks to the 850 people that we had in the beginning. Today we have over 100,000 family members in Apollo. What made this all possible? Not because it's a discovery. They put their hearts and soul into it and used all the other infrastructure that's possible. We got them whatever it was. The first city in the country was bought by us. Today there are 1,000 cities. First MRI was bought by us. First CyberKnife just now worked on that, which for head and neck cancer. We put it in Delhi, the first 10 in the world. And the man who discovered John Adler, he's going to come next month to inaugurate that. So we backed him up with the technology that's required. So, and everyone, they saw that they can do better and did marvelous things. You know, for example, in heart, we have overtaken Bill and now over 200,000 coronary bypass surgeries. Leave alone the interventional cardiology, structural heart. So many things that happen everywhere in the world is being done here by our people. It is Indian doctors, Indian supporting staff, which is making all this possible. For example, in transplant, we're number 1 in the world, but done 23,000 transplants. Heart now. In one case, heart and liver transplant simultaneously. So all of this, liver transplant, renal transplant, were done the largest of 0.2% of the global numbers, 23,000. But we are number 1. Nobody even crossed 20,000. So I think this is all possible because you and I have the same feeling that we must do the best to our patient. So I think this is another attempt, whatever we have done, as you know, in this 40 years, there was a great transition in the services that have been provided by the healthcare in India. And I want to compliment not just the public healthcare, the private healthcare who made a significant difference in the unknown COVID, which you never saw anything like it. But it's tremendous. Compared to the world, our mortality rate is 0.8%. US mortality rate is 2.7%. So I think that's because I think we put our hearts into it. So this is where I thought now that our 40th anniversary is coming, we will continuously doing something on the earth globe. You know, whatever technology that's available, whatever new procedures that are available, have all been done. Robots, for example, we have crossed over 10,000 robots. Not only robots, we probably got the largest number of robotic cardiac surgeries. You know, imagine, cutting out the rib this one. Robotic cardiac surgeries, both of you from here, Dr. Sati from Bangalore, they have done the largest number of series in the world in the robotic heart surgery. So I think this is all possible by adaptation of the technology. And today, possibly with the technology, we are almost up there. Calcutta has already got article in the 5, whatever that is. But we are now on 4. So once that comes in, we are all prepared. For example, our ambulances will have artificial intelligence The two people that go in the ambulance are trained by a course started by Stanford, but we give the course already. So the treatment will start at home. Then they can bring to your place safely. Otherwise, in India, the heart attacks are very encouraged and more severe. So very few survive if they are not close to a hospital or did not reach a hospital in time. If they reach the hospital in time, we put miracles. Your plastics, your surgery, in all these you are wrong with the rest of the world. And confidently we can say we have done better than vessel centers anywhere in the world. In cardiology, we take treatment rate. I think in treatment rate and our story is the same. We have done with immediate survival over 94.4, 1 year survival above 98%. So I think all of these are possible because we want to put our hearts into it. So this is why we thought, what more can we do now that the technology rapidly come in the last 2 years? So using technology, how can we reach people? Way back in 2002, when Bill Clinton came to Hyderabad, I had my building connected with the first satellite television in the world. I had my building connected and connected to Hyderabad, Dr. Rao, in Hyderabad cardiology. And it was seen by Dr. Bill Clinton in the exhibition. So there was an young girl who was being done in my village. And that has been transmitted to Hyderabad. Hyderabad doctor advised the mother, your child has got a hole in the heart. During vacation, bring it to her, we'll sit and people go back to school. He has run down to his clinic side and then said, Dr. Reddy, this is a remarkable thing that what you've done. The rest of the world should follow your lead so that people in the remote areas will get the benefit of high-tech medicine. So I think this is exactly what we want to do today. To see how we can take care. But we have 700 specialists in the whole group. If all of them give some support, it can support many more people. But it's not possible. The world is short of people, doctors. The world is very short of specialists. So I think you are doing a great work because you are the first point for the patient care. You are the first point. You are the real savior of the patient because you attended to him, stabilized his condition, and cured him. Otherwise, you send him to another hospital. So when I say another hospital, whenever you become a member of this, it is not necessary that you stay only the world. To whomever you want, you can refer the patient there. But our opinion will be given to us 24/7. I hope all of you see in the command station. So we kept one of the state-of-the-art command station. It can take nearly 10,000 calls a day. So this is where 3 or 4 centers of ours are now ready. But all our hospitals, 70 hospitals, will have this type of connectivity, supporting the primary and secondary care hospitals when necessary. But you will probably have an MBBS doctor. You can't expect him to treat complications. Suppose if I let this my patient get he won't know what. But that advice you can get from us around the problem. So I think this is one of the things that we have done. But there are 2 or 3 other things we should like to do. Using the development in threat to the biggest threat that this decade has got is an ongoing disease. The diabetes, the heart attack, the stroke. Heart attacks and strokes occur anywhere in India. They were never seen. I remember 1974, I had about 8 patients in 30s who had a heart attack. When I presented in American cardiology, they said, Dr. Reddy, he has known the date of birth. I said, don't be foolish. They didn't even know the star under which they are born. So 7 years later, when they realized, 3 doctors didn't grab to the duty room in the US, and all 3 were doctors. Then hell broke out. So they ate a lot of beef, they ate a lot of coconut oil. I said, that's also foolish. And my mother-in-law who takes not teaspoon, tablespoons of ghee, and she's perfectly ready. So now we know the gene which came 3 centuries ago and which altered the gene for South Asian. I think there are peculiar questions. Even our textbook cannot give us the right answer for all the people all over the world. This is where I think our mutual conversation and mutual discussion will enlighten us as to what the real problem is, how to solve that problem. This is where we would like to coordinate with all of you. I said, fortunately, the technology is easily supported. There is a minimum that you need to do. But I want to tell at this time, Apollo Connect is not my idea. It is done 20 years ago. I went to Cleveland. I went and drove 30 miles and saw one of their connected clinics. So they give second opinion. Here we want to monitor you and give you continuous help. Of course, second opinion we've been giving for the last 20 years. We've been giving second opinion, especially in oncology. I think we get a number of calls every day. And, but even otherwise, we've been getting, and we do the tumor board. All of this will happen. But I think that for this particular thing, it is for acute emergency. There is an emergency floor or in the ICCU. Ramakrishnan is heading our ICCU here from day one. I think we were one of the first who did very best. Example, JCI certified all our 8 hospitals. Every time is the first time. Even Singapore General, they paid 3 times. So our hospitals were first time, JCI in all our hospitals. So I think that only shows we have the intelligence, we have the power within, how to channel it properly. So this is where I think I want you and us to go together, to make a difference for that guy. So when he comes there, he doesn't know what he has, but he knows he is sick. But it could be highly complicated. Or a simple case which you are treating regularly. In that, we would like to be partner with you, to assist you, to make a system. Again, here in US, for Mayo charges, for one discipline, 3 crores a year, subscription. So I said, if I fill the 3 crores a year, I probably have one generous person who would use it. But all this will lie idle. And our thing saying, we want to help the last person, it will not happen. So we kept it very low. And even other things, second opinion, everything, for the members, we thought we will give a 10-15% discount in things that are already happening too. So that more and more people can use. Unfortunately, as I said, we have over 7,000 specialists who can handle this. And we will grow, you will grow. Well, our intention is, you and I want the same thing. The person who is trusted in us came to us and we gave the very best. So I think the Apollo Connect will make a significant impact in your managing that patient and asking for second advice. And of course, if it doesn't respond, our doctors also are seeing it and they will say, maybe, do it. So primary responsibility is with your doctor there. So that's why I said we should always recognize only a doctor who is MBBS will be available 24/7. Only they should come. Now, if you ask me, what is your commission, Dr. Reddy? How many national homes you want to, primary hospitals you want to attend? I have no. I said, first we'll do a couple of hundred. Then we'll do 1,000. The other day, Malaysian government came to me because, we put proton 4 years ago. Actually, the government of India took 4 years to give me permission. Then we started proton. There was no proton in India. Whole of Southeast Asia, Singapore, Australia didn't have. The patients are coming in just now. They started in Singapore. And Malaysia invited us to select the site for them, to select the equipment for them, and operation engine for 5 years. So I think this is a recognition that Indian doctors in other countries have always shown that they are right. But somehow, although we have 4 C's, I always say Indian healthcare today has the 4 C's: the clinical competence, the care and compassion, which you can't buy with the Jewish company at all, and finally our cost effectiveness. But unfortunately, the cost effectiveness in the West, they think it is cheap. Now, how can they do a bypass of $5,000? How can they do a $4,000 bypass? And the government of India wants you to do it for $1,000. So, but in any case, I think whatever it is, the outcomes is what really matters. Outcomes in coronary surgery becomes so cheap. And we have a doctor in Bangalore, Dr. Satiki. He did a maximum number of minimal invasive surgeries. So now one day he called me, sir, I would like to have a robot. I went for a training and came back for 1 week. We gave it to them 1 week. I gave the robot. They were supposed to go to Vizag, I have a diabetic training. And he has done a large number. So Dr. Yusuf from here, he said he also went for a training. Now Yusuf has about taking Dr. Sadi. He has done about 170, 300 robotics, cardiac surgery. Imagine the precision at which the robot does and less complication, and they go home early on the third day. So all of these, we are not behind. That is what we would like to see, even for all of you. What is it that we can do that you can use that extra care for your patient? So, my invitation is, and in the beginning we'll take only a few people, stabilize the whole thing. We'll probably take about a couple of 100 people to start with. Now, Malaysia wants it, Sri Lanka wants it, a couple of African countries want it, Saudi Arabia, one of the foremost, he's coming to get connected. But I'm not going to give it to them for 3 or 4 months. First, I want to satisfy that everything goes beautifully. Technology is, probably foolproof, but we must get satisfied that it works perfectly and it makes a big difference for the patient. So this is another thing that we all know. Before, we never expected COVID. We all done great work during COVID. We launched a IT called 24/7. I don't know how many of you know that. You can go at 24/7, get any of our doctors for opinion. You can get your medicines for your patient. You can get your medical disposables, whatever you want. All of these are available in 24/7. It's already treated about 30 million people. So it came just at the time of COVID. And it's a very big difference. I hope you all know how we handled COVID. First time in the world. We had 5,000 hotel rooms, 3,500 hospital beds. So the doctor will take on the call, take to the patient. Your symptoms doesn't suggest they should be in the hospital. You go to the nursing home. So my nurse was there, our housekeeping person was there. They managed it, and the doctor came online and said, probably 1 out of 15 needed to come to hospital. But the rest of them got shares from the. So, and like that, I think we can innovate. But for innovation, what we need is we need our minds to get to work together. I think when we start with this, I'm sure we'll do many, many more things together. And when ourselves, doctors, our doctors are God. So we must do some part of God to help the patient. So I think you've all done it. You have done much more than that. Because you are the front barricade for the person. So you have done more than that. Again, now, what can we do together to help you give better care for the patient and continuous care? But the disease doesn't select the time. It comes at 4 in the morning, it comes at midnight, It comes early morning. So it doesn't have a timing. So this is where I think our connectivity will help us 24/7 to make that difference. So then I think together we can discuss what more we can do. That we, right? Maybe 6 months later we can meet again. And then say, this is what we did. I wish we can do some more things. God bless you all. You have gone, an appreciation for what you're doing during COVID. No one expected. We take the word. Mortality in India is less than the United States. This shows your commitment. All the doctors supporting staff, their commitment. So I want to pay my respects to all of them. God bless you.
Thank you, Chairman. It's always a privilege listening to you. Now the forum is open for Q&A session. I request the dignitaries who have joined with us over here to ask a few questions.
Anyone would like to ask any questions? Please raise your hand. We'll just pass on the mic.
Very good morning. Happy to connect with Apollo Connect. That's why I am the chairman and national service. And chairman of Prime Minister. So already we know each other very well. And the people are experts also. So how we can connect with you regarding the issue patient scan, whether we can have the separate system, we can come and visit our website, or through the internet and as well as the digital market, how we can give you opinion. And whenever there is necessity, a person can come and visit our site also.
So the advantage of doing it remotely or through connected care is that, we can talk to you immediately. One of our consultants can see the patients, talk to the care provider there, and that way at least provide the initial level of care that you want there. And then, depending on the situation, either continue to help you care in your own hospital or transfer, or if you really think one of you should come and visit, we're happy to do that. So, which we have done before. So, I mean, that used to be through phone calls, but I think this one would enable an extra level where we can actually see the patient and help your team manage the patient there.
Thanks. We introduced Professor Mahajan was the Royal College president last year, and he now joined us, and he given a lot of to coordinate with all of our doctors. And we have Anupam Zipper. He is our director, group medical director, he stays in Delhi, but very active. Many programs, including the Global Association of Physicians, which I started. We had about 30 members before. Now I think we have 3,000 members.
May I invite Dr. Anupam Zipper, sir, to address the gallery.
Respected Chairman Padam Vibhushan, Dr. Pratap Reddy, our founder and chairman, colleagues from the Apollo ecosystem and Apollo family, and of course, colleagues from the medical fraternity. Namaste. It's a privilege to be able to join all of you. It's really interesting that, a few colleagues who have nursing homes in smaller places asked, hey, why is Apollo even doing this? And the answer to that is very simple, that our chairman has always thought about the country first. Years ago, we used to debate on why don't we acquire hospitals? And chairman would say, how does that help India? just because Hospital A becomes Apollo Hospital does not help India. We need to build beds, so Apollo will build. The same applied to training. The same applied to bringing together all the essential components and actually help create and run a fine medical institution. So Chairman often says that, I come from a small village in Argonda, and quite often I think, if I was running a small nursing home in a small place, what would my challenges be? And it is this thinking, it is this ethos that has brought together this Apollo Connect program. See, in 2023, the expectations of the patient sometimes are actually unreal. They don't see that you might be 300 kilometers away from a metro. But when it comes to a family member, they want the very best that happens anywhere in the West, in the best centers in the US, to be delivered to their relative in that small facility. That is the reality of today. That is the expectation of the patient. And I think that is absolutely right, because everybody wants the very best for their family members. So how do we actually bridge this divide? India is producing 107,493 MBBS doctors starting this year. We have 64,000 postgraduates. But guess what? The total number of DM seats for critical care, 71. Let me say that again. 71 seats for critical care in India in DM. So can we ever fulfill the need that exists in a country with 1.4 billion people by having intensivists in every hospital in the country? It's not going to happen. It doesn't happen in the United States. It's not going to happen in India. So that's where we have to be cognizant of the fact that we can use technology to break these geographical barriers and provide care which is comparable to the best care that could happen in a tertiary level hospital in a small nursing home. And that's really the reason why we've come together to develop this program. And there are, it's not just about teleconsults. It's not just about teleradiology. It's not about telecardiology alone. It's not about tele-ICU. It's also about areas that many of us have not explored. Digital pathology. Let me give you an example. You have a rare renal tumor. How many nephrology specific pathologists does India have? So we've mapped all our pathologists in the country, and there are 13 subspecialties of pathology today. So if there is a rare liver pathology, then there is a liver pathologist who can look at the slides on his computer and give an opinion. So there are just so many opportunities that I think we can avail of by using technology. And also friends have said, we are second generation. We run this hospital. My wife and I run it. Now we want our next generation to come in and actually run a more efficient hospital. Can you help? Of course we can, because at the end of the day, it's all about pushing the Indian community to the next, medical community to the next level. It's about pushing Indian healthcare to the next level. So please send us your managers, your children, anyone in the family that you want to train, and let them sit with HR, let them sit with finance, let them sit with procurement, let them sit in operations, let them sit with a medical director. And whatever we have learned over 40 years, we will pass on to you and your family. If there is anything that's bothering you about any clinical problem, pick up the phone and call up people in the closest hospital, and they will take your call, and whatever advice, whatever assistance we can offer, we will be there, because it's really about the community coming together. It's about together making a big difference. That's why we are launching this program. This is a program that, as Chairman said, we are just about starting. So please give us your suggestion, give us your ideas. And Chairman has always believed, and in every initiative that Apollo has launched, he always says, give suggestions, give ideas. Let's start small, then build it really big. But of course, in typical Apollo style and Chairman's vision, build it big very quickly and follow through to create something that actually has impact. Thank you so much for joining us today. Thank you, Chairman, for actually doing the inauguration yourself. And congratulations to Ravi, to Rahul, to Dr. Hari Prasad, to Sai, to our amazing intensive care team in Chennai and everywhere. And, if I start taking names, it'll perhaps take 5 minutes, so I won't. But on behalf of everyone, we're absolutely delighted that you are here to partner with us, and we will give you 100%. And Chairman never says support. It's going to be a partnership. So it's going to be 100% partnership where we will learn from you, and whatever we have to offer, we will offer to you in terms of our experience. Thank you so much.
Thank you, sir. Now I request Dr. Vinay Chelar from Mumbai and Dr. Rajiv Kumar Singh from Bahar Medical Research Center to share their ideas.
Namaste. Good morning to Chairman sir. It is my heartiest congratulations to you for this wonderful Apollo Connect program, bringing the healthcare together. I am Dr. Rajiv Kumar Singh, Director of Bahar Medical Research Center, Bihar. We are connected with Apollo Tele ICU, and now it is very easy to manage critical care patients. There is some cost restriction also. Many people do not want to go to the metros where costs are very high, and this Apollo ICU, you can manage the patient in periphery with the same integrity and same health facility. This is one of the good factors. Then, secondly, the patients and the attendants, they are very much happy that we are getting the tertiary care centers advice and manage the patient in the peripheral ICU also. So it is very helpful to us. Again, we are really very happy to associate with the Apollo Hospital Connect program. Thank you very much.
Good morning and thank you, Chairman sir. That is sir, Dr. Akshay. Yeah. Thank you all for giving me time. I'm happy to share with you. Hello. Thank you for giving me this opportunity. I'm with Apollo eConnect since last 10 days. This started me, and basically I'm an MD Medicine. I was in Hinduja for critical care training, and since last 20 years I'm practicing. I have my own 35-bed hospital. I'm having with all the facilities like 3 ventilators, dialysis machine, BiPAPs, stress test, echo, everything. So my setup is nearby Apollo. I'm practicing Palwell. The thing is that in my setup, or we can call it as a nursing home setup, many of the times a patient gets admitted and the patients are close to me. So their worry is that if their patient is critical, then what to do next? They believe on me, that's why they want to continue the treatment with me. But they always say that if you want, you can call any super specialist from anywhere. We are ready to pay, but we want to continue the treatment. On the same line, this concept came to me. We are in touch with the Apollo. So I started this set 10 days back. Then this is active since 10 days. Just I want to give 2 examples. One patient who was in my hospital for 6-7 days, and he was shifted out of ICU, and again he went in distress. She was shifted again in the ICU, and then culture reports came. The culture was done on Vitek automated system by microbiologist, and the bug was resistant to all. So I was in a big dilemma what to do next. Then with this system, I was in touch with Apollo. During throughout the day, they are in touch, taking the records from the patients. Then I discussed this case with the infectious disease specialist, and the treatment was changed accordingly. And within a span of 48 to 72 hours, patient responded to the treatment. So I got the benefit in that case. Second case is my colleague, friend, and chairman of our society was. He came to me with the gastritis-like symptoms, but I said this is a cardiac. I admitted him in the ICU. Immediately ECG was done, but this was a case of we cannot thrombolyze the patient because ST depression and T inversion was there, even though there was typical angina. So I was in touch with the Apollo. Immediately took the consultation with the cardiologist from the Apollo, and then patient was shifted here. Immediately cath lab was ready. Emergency basis, PAMI was done. He was stabilized and he was discharged in 3 days. because nowadays it's very risky to keep such patients at my hospital. If the patient goes in post-thrombolysis, arrhythmias or anything else, this patient was not case of thrombolysis, but if the patient develops arrhythmias, that will be a big problem. So at the earliest, I would like to shift the patient in such, but on emergency basis, I got the help from the Apollo. So I'm now, since last 10 days, I'm daily in touch with Apollo for critical cases and getting support. For nursing home patients, that is the biggest advantage, that those patients, they don't want to shift to tertiary care. In such case, they can definitely guide us. So thank you all the Apollo team, Marathi sir, Abhay sir, Dr. Akshay and Bhumika ma'am and her team for giving me this opportunity. Thank you. Thanks a lot.
Now I request and invite Professor Ravi Mahajan, a Critical Care Integration and Transformation Apollo Group, Director Research and Innovation Apollo Group. Please, sir.
Thank you very much. So, as we've just heard the cases from Mumbai, it's the first time I'm hearing. I'm so pleased to hear that we could look after two of the critical care patients. Their critical care patients, treat them where they belonged, which is great. But also, when required, they could be transferred very quickly and the hospitals were ready. That's the whole point of comprehensive connected care, that we are connected, we are monitoring your patients wherever they are, whether they are in the ambulance, whether they are in your facility, whether they are in transit, or whether when they go home, we are able to intervene and we are able to do something. I think that's takes us to the next stage, and that makes us very unique, not only in India, but also I'm sitting here in the UK at present. I'm talking to colleagues here. They haven't got anything like that in the UK as we speak, but they are keen to build that. So I think we are in a position here now with Chairman's vision and his inspiration and his blessings to create something unique in the world, which is comprehensive connected care, so the patients get the best possible care irrespective of their geographical location. And the examples that we heard from Mumbai are great. So thank you very much for that. Are there any other examples or anybody else who wants to speak? I believe we've got some nursing home owners from or secondary care specialists from Delhi who would like to say something?
I am Dr. Ajay Gupta from Muzaffarnagar, UP. I had connection with your center as Apollo Information Center 2 years back. I think the patient who goes from our hospital to Apollo Hospital, they should be given some priority, some benefits, so that patients' acceptability about our hospital also will increase. This is my suggestion. Thank you.
So, Dr. Ajay, of course, as partners, we are here to look after each other. And more partnerships, as Dr. Sibal just said, the partnership is about 100% partnership. So it's not just the case of priority, it's the case of working together. So it's not you as somebody distinct from Apollo. You become part of Apollo, you become member of family in that way. And that's the philosophy of our chairman. So obviously, as partner of Apollo Connect program, you are one of us and we are one of you. So that's the whole philosophy. I hope I answered your question.
As you just said it, that to retain the patients, and to acceptability, we have to give some priorities to the patient, so that patient should become affluent with us also as well as Apollo.
I agree with you entirely, and that's the plan, definitely. Thank you. So, any further questions. I think Dr. S.K. Goyal wants to share some feedback.
Dr. S.K. Goyal, I did DM cardiology from Institute of Medical Sciences, Banaras Hindu University in 1991. And by the time when specialists were hardly available in the remote part of UP, especially, and at that time I chose Bulandshahr work as a specialist. And over 32 years, I have more than 500 survivors of cardiac arrest in my setup. And this setup is running for the last 32 years, initially as a clinic, then started as a small hospital, and for the last 13 years, I'm running a cath lab at Bulandshahr. And the Apollo Hospital has supported a lot to me in this journey. I joined Dr. S.K. Gupta in 1997 as a visiting cardiologist. Apollo Hospital allowed me to work in the hospital and to learn the technology. And I'm in touch with the Apollo Hospital for getting myself updated and to get the services of the doctors also at Bulandshahr. And for the last 1 year, Apollo Super Specialty OPD is also running at Bulandshahr. And my aim was to provide services to the rural people of India, especially the district of Bulandshahr. Many of the people are not able to understand the problem of cardiac pain. They take it as a gaseous disturbance, epigastric pain, or gastrointestinal burn as a gastritis, and they do have cardiac problem and acute MI. So this had helped people of rural India in real sense, and I'm running a 30-bedded hospital now. And in recent time, I'm going to start cardiac bypass surgery at Bulandshahr with the help of Apollo Hospital. And this Apollo Connect clinic and Apollo Connect application will help a lot to the people of rural India. And I thank Dr. Reddy for making this platform for the benefit of the society, for the benefit of rural India. Thank you.
Thank you very much, Dr. S.K. Gupta. It's real pleasure, Dr. S.K. Goyal. It's real pleasure to hear such positive words from you. And I'm hoping that we've got today, potentially 300 to 400 partners in various places. As you can see, we're connected from Delhi, from Calcutta, from Hyderabad, from Bangalore, from Chennai, and from Mumbai. So you're all here representing national secondary care. And with the partnership that we're proposing, we will be entering a new era of providing the best possible care to all our patients all over India and outside India. So with those remarks, I think we come to end of our program, and all it remains for me to do is to thank everyone involved, our regional CEOs, our unit heads, all the people who've worked in the background. There's a long list of thank yous. And thank you, Chairman, for being here, for inspiring us, continue to inspire us, and continue to think, make us think of doing something unique and something unparalleled, which is, I'm sure, is what we've done today, and we hope to continue to build on it. With those remarks, thank you all for being here, and enjoy your rest of stay in whichever facility you are in. Make sure that you visit your local command centers just to see how the facilities are panning out and what Apollo is planning to do in terms of comprehensive connected care. Thank you, ladies and gentlemen. Take care and have the rest of the day an enjoyable one. Thank you very much. Take care.
Ladies and gentlemen, that concludes the formal proceeding of this event. I request every one of you to join with us in the lobby for a group picture, followed which we will have our facility tour, and lunch has been organized in Levisto. Please stay back and join with us. Thank you.
Good afternoon, all. We all have gone through the concept of Apollo Connect. which actually bridging a gap between the nursing homes and Apollo Hospital. The basic crux of the concept is basically the Apollo is working on three principles where actually the nursing home can build their practice, scale their business, and retain their patients. So what I would like to say that there are 3 R's basically: the retention of patient. The Apollo Nursing Home Connect program would help you to retain your patients. Then the Apollo would help you to retain your business also, because once you lose that patient, once you refer that patient to an higher center, probably it is a loss of revenue for you also. And then there is a retention of credentials also. Once you refer that patient to an higher center, it means that there is a reputation loss also, because there is a perception, the people may perceive, the relatives of the patient may perceive that the kind of treatment is not available at this nursing home. So how we can work on these 3 aspects where the Apollo would act as a big brother and would help you to grow in your own domain, in your own territory. To enlighten on that fact, there is a detailed presentation for which I would like to call Mr. Santosh Marathe, who is a regional CEO, who would give you a brief about the entire Nursing Home Connect concept, and will take this forward. Please, sir.
Afternoon all. Once again, thank you very much for spending your Sunday with us. And though the presentation was done as a part of the overall overview as we saw in Chennai, I would like to quickly run through the overall presentation just to give more clarity in terms of this thing. Before I begin the presentation, a couple of things. I think though we are officially launching Apollo Connect today, in some shape or form, I think most of you sitting in this room have been connected with Apollo, directly or indirectly. Especially during COVID times, especially during vaccination times, I think we are proud of the kind of work that all of you individually and collectively have done in the community. And there is a reason why only select people are being invited today. Definitely we are proud of the kind of work, what has been done by you individually in your own setup. And as we have partnered earlier also in multiple initiatives, whether it can be cases referred from you, whether it can be partnering with capacity building initiatives, few of you people have already started sending their staff at our end over here. One of the important elements what Apollo has also learned in the last 41 years now, the whole manner in how healthcare gets accessed is undergoing a radical change. People don't want to travel. People, as few of you already have narrated, people would like healthcare to be done in the vicinity of their neighborhood where they stay. They just don't want to travel. And with the kind of thing, if we could collaborate, and there is so much to offer from Apollo, in 41 years, whatever we have learnt over the period of years, I think, and most of you are aware that in the COVID times, we had created a book which was known as Red Book. That Red Book was made available to all nursing homes without any charge, without any cost. That was the vision, and that is the overall vision of our chairman and Apollo team, is to share our best learning, best practices and leverage it in the community. So I will quickly take you through the presentation. So as we are seeing, I think post-COVID, the manner in how healthcare is getting provided and also how it is getting availed by the patients have undergone a radical change. And we are seeing it, not only the Apollo unit in Maharashtra, but also pan-India. And that's the reason the whole concept that we started working on in the last almost a year now, where we wanted it to be shaped up in a particular manner. And again, I repeat that there is so much to be offered from Apollo. I think definitely there cannot be one standard module which can be given, and that's the reason the whole perspective of putting this module together was to give you multiple offerings where you can pick and choose what is relevant to you. So again, coming back to the overall thing, I think the healthcare landscape has changed. Technology adoption has enhanced. People don't like to travel more and more. They would like their healthcare needs to be localized as far as their overall activities are concerned. And networking has really worked well. All of us have seen it brilliantly well during COVID times, where most of us went out of our way, especially our clinicians, the nursing team, the technicians, really have gone out of the way to partner with each other. And that's the reasoning we are looking at a networking initiative and the partnership initiative. This is a clear vision from our chairman. By the way, our chairman's age is 91. It has been almost 41 years that Apollo started, and our chairman started the Apollo unit when he was at 51 years of age. So at the age which most of the people want to retire, here is a visionary who started creating the concept of a private hospital in the Indian segment. And in the last 41 years, we are also proud in the kind of segment of the work that Apollo has done. We have 77 hospitals pan-India. And obviously this is the 62nd hospital, which we started almost 7 years ago. So again, I think the Apollo Connect, the whole concept is getting into standardization of care practices. Unfortunately, in the Indian context, as we all understand, there is so much talked and done about standardizing cost, but not much has been done in terms of standardizing care practices. Few of the hospital setups do undertake JCI, do undertake NABH, do undertake accreditation standard. And that is one of the obligation which we as healthcare leaders in the Indian context think that the overall elevation, standard of care should be elevated in the region. And that's the reason this initiative has been undertaken. And while doing that, obviously we want to safeguard individual interest of individual consultants. Like most of the speakers in the morning also said, there is a legacy why you have created your own nursing home in the region. And we would like to partner with you to leave that legacy along with your children, along with your whoever is taking care of the nursing homes. We would like to build capacity with them. And again, I repeat, there is so much to be offered within the Apollo ecosystem. Please be mindful and please be selective. In wherever you think that Apollo can add value, we will be more than happy to add value. And another important element, which we have been encouraging most of the nursing homes now, in most of the cases when you refer cases to us, we would encourage you to visit the hospital and see the patient with our treating consultant. That kind of care journey, if you could create the continuum of care, because these are cases who are always referred into your hospital setup. These are families who have been availing care into your setup. And that's the reason we encourage that at any point of time when you refer a case for standardized care where patients cannot be stabilized or that kind of care cannot be provided over there, we encourage you or your treating consultants to come into the ecosystem, take joint rounds with our consultant. That will give that sense of confidence, and also the patient will come back to your ecosystem. That's one of the encouraging element which we would like to take. So the key services, I think most of it has been talked about. Obviously, we want to focus on boosting and developing your own setup in terms of how we can do. There is a lot of cost correction initiatives that Apollo has done meaningfully well over a period of time. We'll be happy to share those kind of practices. There is a reference point of economies of scale. With Pan-India 77 hospital, Apollo enjoys the best of the procurement rates, whether it is pharmacy, whether it is medical consumable, whether it is medical equipment. As a part of this partnership initiative, we would like you to be working as an extended arm of Apollo and take all those benefits to your advantage. So that's one of the important elements what we are seeing. Within the Apollo ecosystem, apart from the hospitals, there are some 17 or 18 subdomains that we operate in. There is a separate domain for Apollo Diagnostics. There is a separate domain for Apollo Clinics. There is a separate chain of pharmacy, chain of shops. We have some 7,000 plus pharmacy shops as we talk, pan-India. So obviously all those economies of scale and strengths what we have. There is a detailed lab which are being institutionalized in individual hospitals. We are also setting up a state-of-art lab in Hyderabad for genetic medicine. So all this kind of leveraging element will definitely give you good qualitative reporting while reducing the overall cost of care which is being provided over there. And obviously our area of interest will be strategic support, where meaningfully we can look at the quality outcomes, where we can look at capacity building for your own nursing staff, for your own technicians, or for your own junior doctor members. We will encourage them to what we call it as observership programs. They can come and spend 3 to 4 weeks in the hospital or a larger time if you think. They can get access to the best of technology. They can get access to the most of the senior consultants that we have in the hospital. As we speak, Apollo Navi Mumbai has 110 full-time consultants at Apollo. So this is another unique concept. While most of the other setups in Mumbai region work on a concept what is known as visiting consultants. We are proud that we have invested in those kind of senior consultants. So at any point of time, if there is an emergency case or any acute MI or any kind of road traffic accident, most of my senior consultants are available in the campus within half an hour to 45 minutes. That's the strength of continuum of care. And that's the same access under Apollo Connect, which we will like to offer to you. And obviously training and mentoring in terms of observership and this thing. There is another vertical under Apollo, which is known as MedVarsity, which offers curriculum courses, certification courses. So those are also the avenues which can be available to your team, your clinical partners, wherever you think meaningfully. And it is very, very important for all of us under the clinical care journey to keep ourselves motivated first. And second important part is to keep touching up and living up to the expectation of changing and evolving technology. There are so much radical changes that are happening in the medical field. And that's the reason this kind of certification courses, observership courses really become handy in building capacity of individuals. I think by and large we have covered most of this aspect. Another important element that we talked about is full-time consultants which are available in the ecosystem. At any point of time when you are undertaking multiple care opportunities, if there is a need to do a cross-reference to a super specialist, those options can be available under your overall thing. And as most of you must be aware, during COVID times, we had really strengthened our digital footprint in terms of strengthening our 24/7 app. So under your mobile app itself, most of the digital and virtual consults are available. So that is one of the options. We can also look at telemedicine facility to be set up within your own system, where most of the consultants, our ER and ICU setup is manned 24/7 by senior consultants. So those kind of access points at any point of time, whether it is midnight, working hours or post-working hours, any point of time, those kind of secondary opinions and second opinions which are needed can be accessed under this overall activity. Teleradiology, telediagnostics, all these elements that we have talked about already. This again we have mostly covered in terms of the overall talk. This again, I think by and large, in the interest of time, I would like to skip through this. And obviously we are also looking at co-branding initiative. I think Apollo as a brand is very, very powerful brand. And obviously while associating and getting affiliated with the brand, we would like to build that confidence in your community to the beneficiaries who have been availing services at your own setup, what you have garnered and created over a period of last 10 to 15 years. We would like to strengthen it further by joining hands with you with all these multiple initiatives that we talked about. There is also an element of hospital information system. I think most of the nursing homes will be having a setup which is known as billing system, or in some shape or form, you will be calculating and doing most of the medical and clinical documentation. One of the things what Apollo has learned over a period of time, as overall unit become more and more scalable, where you move from a one unit entity to a multiple unit entity, having records available in a digital format is always better, because we don't want to keep on duplicating medical records in multiple entities. So that kind of electronic medical record, which Apollo has evolved over the period of 41 years, can be made access under the Apollo Connect program. There is also a single SPOC, dedicated person who will be connected with the nursing home owner or the overall SPOC from your side, once when we tie up under this agreement. Obviously, this is more of a simulated version of what value this kind of Apollo Connect may bring on board. Obviously, it is an indicative figure, but the biggest strength of this program is connecting for intensive care unit. I think most of you have an intensive care unit ranging from 5 beds to almost 15 beds. Those are the areas where definitely Apollo's strength can be leveraged quite appropriately when we look at this kind of model. So indicatively what the team has put up together, there are two models that we are looking at. One is the premium model and the second is the eICU Connect model, what we are looking at. So the premium model indicatively is available at 5 lakh rupees per year, and these are the benefits which are available under it, including branding, including training, protocols, specialist consult, the teleconsults accessibility that we talked about, including the procurement. I think procurement is one of the bigger advantage which most of you Whether it is consumables, whether it is pharmacy, whether it is medical equipment, I think those kind of initiatives can definitely be leveraged in a much better manner in terms of this thing. And more importantly, strategic and accreditation standards. So this is something, while you may want yourself to be ready for NABH, that kind of hand-holding services can be also provided under the Apollo umbrella. One of the things which is not covered over here, but which I would like to talk about it, there is an Apollo project division, where we undertake a lot of turnkey projects in re-looking at retrofitting your existing structure and make it much more patient-friendly and much more safer for the patient in terms of work environment. So those kind of avenues also can be specifically undertaken if you have an intent to expand or remodify your existing structure to make it much more meaningful. And then on the left-hand side, there is an eICU Connect program where we are looking at a 90,000 per month for a 4-bedded ICU setup which is being done. So in essence, as you must have understood, if you take care of the eICU model, then all the premium benefits are already included as a part of this thing. You don't have to pay anything separately for the premium module. And maybe the marketing team and the overall clinical teams can get in touch with you one-on-one to further elaborate and understand your specific needs so that we can customize the model and work out a workable model which can be a good model for you. Lastly, we are just trying to compare in one of the few of the best practices, as most of you must be aware. Mayo Clinic is like the Makkah of healthcare in the Western countries. It is known as the gold standard. Most of the offerings which are done, Mayo follows the same kind of structure, what Apollo is trying to embark now. As is evident in the structure, most of the benefits are even not available in Mayo Clinic because the healthcare dynamics over there are totally different as compared to the Indian context. And we as a part of the Apollo system are very proud the kind of work that Apollo has brought forth in the last 41 years. And definitely we want to expand the overall great activities that Apollo is doing by partnering with all of you. And again, I will end with a note that we are definitely proud and cognizant of the fact that the kind of great work that all of you are doing in your region. And definitely we will be happy to partner with you and understand with you as to how we can work along with you to build and promote your business practices. Thank you. Sorry? Yeah. So we would like the forum to be open. If there are any question answers, if any queries are there, clarifications required, please feel free to ask. Any kind of clarity or any kind of clarification required, obviously we will get in touch with you one-on-one in terms of further elaborating and identifying opportunities where we can get into it. Again, I repeat, what you are seeing is just a glimpse of indicative partnership initiatives where we can partner with. But I'm sure there is a lot more that Apollo can offer, and there can be a lot more which is much more meaningful for you. So if whatever you are trying to do, whatever is your healthcare priority, if it can become a healthcare priority for us, we will be more than happy to partner with you.
I would like to request this particular connect will be handled by clinical, which is more of a clinical team from ICU area and admin team. I would request ICU area doctors and admin team to come ahead so that we can generally show who is the team behind it.
Just quick introductions will be helpful. Come.
Dr. Akshay, Dr. Gunadhar, Dr. Soni, Dr. Divya, Bhumika,
Come, Dr.
Sneha, Sandeep,
Sonal. आजा ऊपर ही आओ.
This is a team basically will handle clinical engagement and administrative engagement as it is shown in the Apollo Connect program.
We have quick introduction. Come here.
So, good morning everybody. I am Dr. Gunadhar Padi. I am the Senior Consultant Critical Care Medicine, and we'll be definitely happy to help whatever the way you people need and whatever the way we can help you. It will be our privilege, and it will be a great platform to learning also for us also, and to improvise our services, and sometimes hand in hand we can develop the good joint ventures for this program. So thank you.
Good afternoon, everyone. I'm Dr. Divya Kukian. I'm a consultant in critical care medicine here. So I have over 13 years of experience in critical care. And our experience is more because we get more of referred patients, so we manage the most sickest of patients. So what we commonly see is that when we get some sick patients, if certain interventions or something is done maybe a day prior or something, then the outcome also can be different. So hopefully with this kind of an intervention, with this kind of a connect, we will be able to help those kind of patients better.
Hi, good morning. I'm Dr. Akshay Devdar. I'm one of the consultants in emergency. So we will always be the first point of contact, and for any time-based interventions, whether it is a transfer from a hospital or your patient coming from home, we'll always be there 24/7 to make sure that we get things done quickly, and obviously with everyone's support from critical care and management team.
Hello everybody, I'm Dr. Subhadeep Sen. I work as a consultant in the critical care department in our hospital. So as it has been stated multiple times, we'll be very much happy to collaborate with people in each and every aspect probably. Whatever way you want, probably we'll be able to happy to help you out in any way. Thank you everybody. We'll look forward seeing more and more your patients in the coming days.
Hello, I'm Dr. Swapnil. I'm also a consultant in critical care department. I'm working in ICU since 10 years, and we are very happy to join you in eConnect program. And it is just to improve the outcome of all patients, and I respect all visions explored and created by our chairman. Thank you very much.
I'm Dr. Ravi Shankar, and I'm the medical director here. I want to reassure everybody that all kinds of supports, right from ER to ICU, from all the clinical medical teams will be supported to you. And in addition, wherever there is a requirement of a second opinion and all that, that will be promptly provided. Whenever there is, during the monitoring, any trigger points, the immediate resolution will be provided and the help will be provided to you. Thank you very much, and we look forward to good association and development of the clinical activities and support system between you and Apollo Hospital. Thank you.
So I think crux is, as sir has rightly said, we definitely know that you are the best in your area. Patient believes you in that particular area. Apollo's role, basically from admin and clinical team, will be to ensure that your kind of a journey is smooth. Wherever you require support or partnership, Apollo will be there, and that experience will be seamless, where your requirement will be 100% fulfilled. Thank you.
My name is Sandeep. I look after the sales and marketing here. While we have the clinical support system that is already put in place, there is also a lot of community engagement that needs to happen at your levels as well, which you are doing on an individual level. Apollo has a lot of learnings that we have had over the past 40 years, which are currently technology driven. So we'll be happy to work with you in trying to see how you can engage with your community as well, using the technology products that we have.
Namaste, my name is Bhumika, and I'm heading the biomedical engineering team at Apollo. And as an engineer, technology is very exciting. So what we have seen, experienced in the EICU, it's really great. And I think this is the future. Though we are starting today, but few years down the line, this is going to be everywhere. So very thrilled. Also, as a patient of Apollo, my father was admitted here last year. I have seen the power of multiple specialities, multiple doctors which are available, where we could approach them and take the benefit of so many specialists. As a patient, I'm talking. And that is the power that we have. And through this program, I think that can be passed on to your patients also. We have seen an example like sir already shared, Shelar sir shared. So very happy and excited, and we'll be available to support you in any possible way. Thank you so much.
I'm Dr. Sneha, the Regional Nursing Director for Apollo Hospitals. All that I will say is that we definitely, as nurses, partner along with the clinical care to bring the best of the outcomes. And I'm sure that you will never regret partnering with us, because we definitely look forward for the best clinical outcomes. And there are a lot of testimonials that are there out into the market there, where you can reach us, and we will be always helpful with your nursing team or with any other team, whether it regarding to the mentoring or taking care. We are there, and you can just outreach us.
Hello, namaste. This is Sonal. I head the operations here. My role out here basically is to
established entire infrastructure at the nursing home. So right from setting up the infrastructure, assisting in connections and internet connectivity, giving the biomedical support and the IT support, we will be all there, and we will ensure that there is a smooth, uninterrupted connection between the command center and the nursing home. So with this, we hope to have more connectivity with you. Thank you so much.
Good afternoon. My name is Abhay Jadhav. I'm a strategic manager. I'm a general manager as a strategic initiative in the marketing department. Basically, as a marketing, what I feel that in 2017, we identified a gap between the nursing home and the hospital relationship. I can take the pride to tell all of you that the entire Nursing Home Connect program is a brainchild of Apollo Hospital, Navi Mumbai. In 2017, we identified a gap that most of the corporate hospital approaches a nursing home and they request for the patient support. They poach the patient from the nursing home, and then there is no support from the corporate hospital to the nursing home. There is only referring patient arrangement with corporate hospital was prevailing at that time. The Apollo as a big brother in 2017, we thought about that, extending this relationship beyond referral arrangement. And at that time, this particular concept was born when the entire leadership stormed on this particular gap and what we can do about the nursing home. So basically this relationship is not in competing with the nursing home, but to complement nursing home in growing their own domain, growing their own business. And I hope with this initiative, we'll continue to bridge that gap between the nursing home and the corporate hospital, particularly with Apollo Hospital, Navi Mumbai. Thanks.
Myself, I am Dr. Nisar Patel, Managing Director, Alpine Hospital, Kharghar. I heard a few very bad experiences. What Mr. Abe say is very good initiative. I agree. If really it happen, it's very, very good. Because I'm from a small village in many our communities, middle class or upper middle class, not rich class. But there are few also. I had most of the patients. I'm a family of 18,000 children. Okay, more than what happened many times. If suppose like you say, you will give support and all that, fine. One doctor, I will not take name. I will not take the name of the hospital or big establishment also. When they will, I will call. They will come. Just will have a look at monitor. It was a already infarct, anterior infarct patient. And patient was established already. So doctor always 1 time, 2, 3, 4 times it happened. So I stopped calling because he will just put in the hand in the pocket and we look at the monitor. Doctor, इसको shift करना पड़ेगा. Okay, fine, बाबा करो क्या करते हो. Okay, 1 patient, 2, 3, 4, 5. Later I thought, why I open hospital? Just for referral. If any shortfall or anything less, you can ask me. I have my ICU, 3-bed ICU, well equipped. Even I have ventilator, support system, bypass type all. Okay. Then doctors should suggest, we may need this thing or that thing, or okay, I will provide, I will bring. But this is not the way. One same gynecologist, also from the big hospital, all parameters, there was no criteria, single criteria for the Caesar. And we would like to have normal delivery most. Okay. नहीं इनका operation करना पड़ेगा. It's okay, fine. अभी gynecologist I don't know much about. She may be knowing much better. 1, 2, 3, 4, same thing. One day I put my foot. I said no. I will shift this patient to another hospital. One of my colleagues is also running hospital. I sent there. देखो इनको आँख पड़ेगा नहीं कुछ इसको बताओ. नॉर्मल होते थे, ठीक है. हाँ, देन आई से ओके डू सीजर. बोले नहीं, सीजर भी करके NICU लगेगा बच्चे को, इसके लिए इनको बड़े हॉस्पिटल ही लेके जाना पड़ेगा. देन आई put my refer to my colleague's hospital. There was a normal delivery, no problem at all with child, with you. Okay, so this type of thing, if it happen, obviously nobody will connect. As you say, this program is very good. I appreciate. If really it happen, really needed, okay, why not? Because we don't have anything to do. They have to, patient, see, patient should get treatment, best treatment, affordable treatment. Even I refer my patient to another hospital many times, just for he will get better treatment. It is not the question of only money. Yes, money is coming automatic. Many. One of my colleagues is here. He may not be knowing even. I have referred doctor to your hospital many patients. Maybe about 25 patients I may have referred. You don't know. You may not be knowing also. But I have referred because you will give better treatment than what I can treat. So this should be the first patient benefit. But of course, economy also coming. But if somebody will start thinking only in terms of money, then problem will start. Okay. So I would like to join in the Apollo Hospital as a Connect member in some form, whatever I will look, all your thing. And then we'll see if it goes well, very good. Even many hospitals will connect. But if, as I say, everything will be in mind, okay, we will lose our revenue in that case. If every patient will be referred, not treated, then obviously people will stop. Why we have start open our hospital, small whatever in terms. Okay, this is my concern.
Thank you.
Yeah.
Thank you for raising these concerns. I think we really appreciate that. Did you raise these concerns to anybody within Apollo at that point of time, sir? So one of the change approach, and I really appreciate you being so candid and giving this feedback. One of the change approach what we are trying to do is, most of the times up till now, I think ये relationship episodic level पे होता है. एक हाथ केस दिया, अपना experience अच्छा नहीं आया, अच्छा हो गया, फिर pattern आप जैसे बोल रहे हो 2 या 3 cases पे हुआ. So somewhere it needed to be escalated. That's the reason the whole approach what we are trying to do. Apart from the Apollo Connect, we want to build tie-up with a nursing home. At the end of the day, there is a particular segment of class which will always continue to come to you. It will not come to Apollo unless and until there is an extreme intervention which is required. But the whole larger picture, what we need to do, and definitely I will connect, the team would like to connect with you offline and try and understand who were these individual people and what was the pattern. But this kind of constructive feedback is good, sir. At the end of the day, it is representing Apollo brand. And that's the reason we are a little bit more sensitive on that. But definitely thank you for escalating it. But the larger picture, what we need to focus on is definitely, I think there is so much to offer and there should be an open dialogue. At any point of time, partnership never works. It's not a one-way communication. It needs to be a two-way communication and we will encourage that. But thank you for bringing it to our attention, sir. Appreciate that.
So to address this point, definitely the SPOC concept is there where a dedicated SPOC will be allocated to nursing home and that feedback will be consistent. And Director Medical Services Office will definitely look all the referral cases and opinion given by them. And subsequently, if some pattern arises out of it, that will be addressed, definitely.
Anybody else has any feedback, clarification? Yeah, please. Sir.
I practice since almost 20 years, 50 kilometers from here, Kalyan. I have a 30-bedded nursing home. My question I myself is MD Chest. My question to your team is in case of the eICU Connect, if in case of any legal implications, what's your stand in that?
I think two approaches what we are thinking through. That's a very good question what you are saying. The larger picture what we want to do is stabilize the patient over there and continue the treatment at the nursing home only. As has been provided a feedback, the interest is not to just mobilize the patient. वो तो आज भी चल ही रहा है. You have ambulances, you have the phone numbers, you do whatever needs to be done. As long as the continuity of the care continues with the treating consultant, it will be only a clinical input. The final decision should be with the treating consultant.
So my question is, see, I have now 10 options to refer my patients, okay? I'm from Hinduja, so there are n number of hospitals. Give me one good reason. Number one, should I refer the patient to Apollo? Second, it's not the question of referral, whether I treat my patient with your collaboration at EICU or I should refer the patient to you. My question is that what is your stand in case of legal implication, if at all arises?
So two approaches are very clear. If the case continues under the care of the nursing home, obviously the legal implication with the primary treating consultant. If the case gets transferred to us, whoever the case gets transferred under at Apollo, the legal implications is with us. We do the assessment of the patient. Once when the assessment of the patient comes into the system, with so much emergency ER department that we have, at times we have picked up patients with not a single relative around. We don't know the financial assessment, we know the medical assessment, but we have treated those kind of cases. And touch wood, those kind of cases have walked out of the hospital also. In terms of
my question is, in case of EICU Connect, if the patient is I'm the primary treating consultant, so if at all any legal implication happens, I'll be held for that, or you will be the
so again,
treating
there are
partner?
two different episodes of care. As long as under Apollo Connect, if a patient is being transferred from your nursing home to our nursing home.
Then it's totally your stand.
Absolutely.
I'm talking about the eConnect program. In eConnect, patient is under
So
my
it will be only a facilitative role.
Yes.
As long as the primary treating consultant continues to be your own treating consultant, the medico-legal interest will rest with her. What Apollo will be doing is an aiding tool. We will be just facilitating you with some kind of inputs, like cross-referral. Jaise hota hai aaj. When we take cross-referral input, still medico-legally the responsibility remains with the main treating consultant.
Okay. Now my second question is, if I ask for super specialist opinion, say nephro or onco, will it be on paper opinion?
Yes.
Right.
Yes, very much.
So see, once you become on paper, then the in case I'm directing the case towards legal implication, because I'm a medical legal consultant also.
Absolutely.
I'm talking about the worst scenario, right? So when you are a partner with me in treatment, so it's your responsibility to be with me in the legal implications.
I'll just give you an answer to that probably. So I'm sorry.
Please.
So in last 5 years, probably if I see the last 5 years or horizon, the tele-ICU concept is being evolved more and more. So there are a lot of tele-ICU setups are being happening. So there are a lot of tele-ICU, even dedicated tele-ICU channels is also there, which provide dedicated ICU care in a remote location. It's a very good question probably that always comes to our mind probably when we talk to each other with this tele-ICU concept. Probably we discuss with each other what is the medical legal aspect of it, like Dr. Gunadhar and I, and we sat together. So we discussed a lot about that thing. And you rightly said, suppose we take some consultations from any doctor, any super specialty doctors, there is some legal implications in that. Suppose I give some opinion and you follow that opinion, the legal implications for that opinion matters to somebody who is giving consultation. Because you are taking opinions for somebody and you are following that thing. Now, having said that, only caveat in the entire spectrum is that somebody is not physically seeing a patient, which is very important in patient care. So that is the only gray hole. So suppose there is one tele-ICU company which is there, the Cloud9, whether you have heard of that company or not, I do not know, but they are working in this model and they are dedicatedly taking care of the patients. It's a Bangalore-based company. They're taking care of the patient in Bihar, UPs and everywhere. So when they work, they have a very robust software, and the software is so robust, even they install a software in that remote location, they even see the patient's pupil as well. So if I can do that kind of complete thorough examination, then their responsibility becomes completely on somebody who is giving consultations. But here what happens, I will work on, probably if I give a kind of eConnect program with you, that point of time, to some extent, my diagnosis on a patient will be based on whatever feedback I'm getting from you. So in that case, it always becomes a shared responsibility. But having said that, if somebody is giving up teleconsultations or online consultations, he cannot deny that he doesn't have any responsibility. But obviously, the caveat is that my input probably my advice probably will be decided by whatever input you give, and the entirely will be decided in that. I hope probably I'm a little bit clear on that thing. So suppose you say that it's a clinical examination. Suppose a patient is breathless, you connect to us. So I'll tell 1, 2, 3, 4, 5. Suppose you do not mention about the pneumothorax and the patient is having pneumothorax and the patient is breathless because of this pneumothorax. So, and I am not able to, because you have not told me and I have not given any feedback about that thing, then the responsibility gets shared. So that is how that is the only drawback in this entire system. Unless I completely examine that patient. You got my point, whatever I mean to say. So it's a shared responsibility. In one way, I cannot say that I don't have any responsibility, but again, my feedback to you probably will be a little decided by whatever input you give me. Suppose you one of the statement is hidden or one of the statement is missed, then the judgment will also be also vary in that aspect probably.
I totally agree.
But again, there is some legal framework has been laid down by now.
It's not been laid till now.
It has been laid.
Has been laid.
So just in a summary, if you go by the medical legal issues, the primary consultant who is there and under whom the patient is admitted, he has to take the medical legal responsibility because he is actively seeing the patient. But of course, if something is being feedback given to us in a tele-ICU manner, we are there to facilitate and proactively do that thing. And with the consultation of the primary consultant. So he has to follow our protocols or our advice that he has to take the proper steps. So that is the major medical responsibilities lies on him only, if the patient is in that center. And whenever you are giving a cross-referral, it has to be on the paper to that particular person. If he or she is able to come and see the patient in your center, then the legal responsibility is shared by that particular consultant. So this is what till now the law is evolving. But it is not still very clear, it is still a grey area.
Exactly. I would, let's examine in this area what my feedback is. Before COVID, the teleconsultation was not legal. But now after COVID, the teleconsultation is legalized. Okay. And when you are seeing the patient teleconsultingly, you are writing on the paper, you are giving us on paper your opinion. Okay. So my say in this that if at all, the treating consultant takes measure of the responsibility, but also the other consultants who have seen the patients are also responsible.
Yes.
The extent of responsibility may vary because as your vision says that you are acting like a elder brother to us, right? Yes. So let's explore in the possibility that be in this also play a role of elder brother. My say is that.
Point well taken, and I am so glad that you brought this subject up, and definitely it's as we expand the concept, which is beyond tele-consultation now. It is much more larger and bigger. I'm glad that you raised this issue. Definitely we will also circle back and get ourselves updated and reach out to you in terms of what can be done. But I think it will be again driven based on episodic, case-on-case basis, where we will have to look at the magnitude of involvement. And in most of the cases, as the team also here is trying to subscribe to, saying that most of the input will be given by the nursing home team only. So we'll be taking it on face value. One of the things what we were also exploring while looking at this concept is to dovetail in physical consults also. So while there will be virtual consults, but if there is a long-standing case which is much more complicated, so rather than getting into a virtual mode, somebody can drive over to your hospital, take a physical consult, take a participative role as a part of this thing, but definitely we will come back to you exactly with what is the medical legal framework. It cannot be definitive in nature because it will be always subjective based on case basis, but definitely we will come back to you on
So
this.
my closing statement would be that this is a marriage kind of thing happening, a partnership you said.
Absolutely.
So let's be together in thick and thin. That's
Absolutely,
all. That's
absolutely.
my
You're
thank
very right.
My request will be when you are visiting our command center, see the documentation part and all that thing also. That will also give a lot of answer, and I think sir will give you that detail because he is already using that. But EICU kind of a model is already evolving in terms of documentation and paperwork. You can visit that in command center.
Yeah, I want to add one thing. As of rightly he said, after COVID, the things are changing. Like we are using, patients are using Practo, 1mg, PharmaSD, and many other apps to consult. They are treating the patients and they are giving proper prescriptions to the patients. It may work on the similar lines that you are giving, taking the history of the patient from us and you are advising something on the paper, so it will be on the similar lines of practo only. Secondly, the advantage with tie-up is that most of the super specialists are my friends. They are ready to come to my place and they are visiting. But with this EICU, eConnect, it is very easy for me to connect them with Akshay, with Amit Nagrik, or with Lakshman Jesani sir, or many other. Immediately, means span of 2, 4, 6 hours. Otherwise, they may come on the same day or may take 1 or 2 days also. But the biggest advantage of eConnect is that I can connect them immediately. Like that case of cardiology, I connected here with the cardiologist and immediately the action was taken. My second query I want to ask regarding the Mediclaim purpose. If I am charging something X amount to my patient in Mediclaim, have you looked after this point that can I charge for these fees to the patient of ICU if the patient is covered under Mediclaim?
I think typically it should come like a cross-referral thing depending upon your tie-up of the insurance company. So typically depending upon the medical prognosis of the case, cross-referrals comes in for review at periodic intervals in terms of this thing. So there should be an affiliation agreement which will tie up with, giving you access to all 110 consultants over here, whether virtual or physical, as you rightly said. So maybe we will evolve that. That's an interesting point what both of you have made. Maybe we will also make a note of it and get pan-India. What is the understanding and standardize it in the interest of everybody's universal understanding on this subject. This is valid discussion.
Many of the times the Mediclaim, they don't accept the cross consultations or extra intensivist charges. So it should be clear from your side that Mediclaim is going to cover for this X amount which we are charging for eConnect.
So you are saying that's a prevalent practice for most of the nursing homes where they don't allow?
Yeah, they don't allow.
No, sir, so any physical presence and consultation which is documented in your indoor case paper, which a consultant has physically given cross-consult, it is covered any across hospital. In e-consult, where it is not physical and documentation is not there, as in today, there is no clarity. IRDA does not subscribe. But you as a center which is affiliated with the EICU and you are getting that benefit, I think your tariff need to be built such a way that this cost is recovered through the room rent or somewhere else. As on today, there is no clarity from IRDA to cover this.
No, rather than giving, otherwise, I'll prefer to, I want to continue this association for long.
Yes.
So, I want to charge the patient directly as a Apollo Connect charges. Whether they will allow
it is
or
not, but I think maybe we will circle back. As you rightly said, maybe Practo under OP episode is available.
Yeah.
But Practo under IP episode, it's something what we will have to think through. Inpatient झाल्यावर काय करता येईल?
Super specialist e-connect charges. I'll bill that and I'll see whether they allow or not.
Yeah.
And from your side also, I request you to see through that.
Definitely.
You can talk to GIPSA or any other Mediclaim.
We will use our good offices with Mediclaims also, medical companies also, insurance companies, and we will try and get clarity on that.
Yeah. Thank you.
They won't pay? Mike.
Because there was no stamp. Even they need stamp also. So how they will not pay? I don't think they will not pay. Insurance company won't pay because I had recently one experience. One Mediclaim, our consultant forgot. We refer him to orthopedic surgeon, and he came. He wrote all the notes with his own handwriting, but he forgot to bring the stamp. He didn't put the stamp. So insurance company didn't pay. They deduct 700 that claim. Consultant, another consultant has seen him. So that bill they didn't pay. No.
Yeah, no, I think overall we will also have to reapproach on looking at documentation review for both the nursing home and for Apollo partners also. Is there an adequacy of documentation? Does the documentation reflect that kind of care pathway which warrants transfer? That's the key concern area. But I think definitely for both the issues, we'll definitely come back to you very clearly on medical legal exposure and the kind of Mediclaim, as you are rightly saying, in terms of and documentation for virtual consults. Anybody else? Any input? Yeah.
Good afternoon, everyone. Good afternoon, sir. I'm Dr. Uday Patil.
Yeah.
I had one question. Suppose the patient, like most of the small, medium nursing homes are run by individual doctor, and now the team is assisting, in admission management. Suppose there's a delay in attending patient, especially night hours. Suppose patient comes, critical patient, the team is managing, there's on-duty doctor, and with the support of the experts, within 3 hours the patient become critical. Then will the patient be admitted under primary consultant, or it will be managed? So what will the scenario like?
Dr. Gunadhar or Swadip, you want to address that?
Like 2 hours patient suppose becomes critical, or
Can you just means I didn't get it properly. Just can you
suppose
repeat?
the patient is admitted suppose 3 a.m. Most of the single consultant, suppose consultant takes time, so he is stuck somewhere, or he within 2 hours suppose the patient becomes critical or say dies. So will that, or sometimes the scenario may come, the consultant for 2-3 hours or maybe 1-2 hours, the main consult takes time. So till then the patient, will it be admitted under the care of the expert team, or how will the situation be managed?
Yes, see, basically what happens now, suppose you have given a admission right to somebody, and ideally he has to come and see as soon as possible. But if suppose he is busy and somebody is taking the responsibility on his behalf, like the critical care team which is present on the that particular situation and particular spot, so he can see the patient and he can do the primary treatment, and then he can inform the primary consultant, and the things can be done as per his orders and instruction. Or second option is like if the primary consultant want, there can be a joint care. Like the intensivist which is there, he can also take the admission right, and he can admit the patient, and the primary consultant can have a joint admission, and he can then decide the plan of care. So that is what. But it is always better that if the case is being referred to somebody, he has to ideally come see and talk to the relative and take the proper decision, so that it will be easier and the medical legal part will be prevented. That is what.
Thank you.
Does it address your concern?
Yes, thank you.
Anybody else? Any questions, clarifications? So thank you again for spending Sunday with us. I think lunch is being served outside, and we will definitely concise all our discussions, which is very helpful. And I'm sure parallelly in all other units also there would have been some interesting discussions like this. So we will give you the benefit of those discussions also. I'm sure those kind of setups will also have some kind of queries or responses on this. So we'll definitely connect with you. Thank you again for your input, insight and commitment to good quality care in the region. Thank you all.